Thank you so much for being back, everyone, at Revolutionizing Healthcare. Today is going to be a specialty spotlight session where we're going to be talking about artificial intelligence in diabetes prevention and care. And we're really excited to be joined today by two amazing guests who I'm going to introduce in just a minute. Today's session will run for 1 hour as usual, and the overall structure will be an introduction followed by presentations by our two panelists, a panel discussion, and then a Q&A chat where you can ask your questions and also feel free to do that throughout the session already in the chat, upvote the most important queries, and then we'll get to those toward the end of the session. Without further ado, let me introduce our two panelists for today. First up is Professor Marta Guasch-Ferré, who's an associate professor and the deputy head of section at the Department of Public Health and the section of epidemiology at the University of Copenhagen and Novo Nordisk Foundation for Basic Metabolic Research, and also an adjunct associate professor at the Harvard School of Public Health. We're also very excited to be joined today by Professor Joaquin Dopazo, who's the head of the computational medicine platform of Andalusia in Spain and at the Progress and Health Foundation in Sevilla, Spain. He's also the head of functional genomics node of the Spanish National Bioinformatics Institute. Thank you both so much for being here today, and I would like to hand over to you, Joaquin, to get us started.
Thank you very much for inviting me. It's a pleasure being in this session that I actually saw some of them, and it is for me an honor to be here. So let me start by a very short, probably unnecessary introduction to diabetes, and why diabetes is so challenging. So this is a disease, a very prevalent disease. It's a chronic, heterogeneous, affecting to a lot of people, to more than 500 million globally. And it's a very complex disease because it has a multifactorial etiology in which genetics, lifestyle, and environment play a role. It changes across time, it's progressive, and it needs continuous monitoring. Typically, it courses with comorbidities and high burden comorbidities. And from the point of view of healthcare, it's a high cost disease with both clinical and socioeconomic cost. So we can say that diabetes is not one disease, but many different ways of arriving to this complex disease needing personalized and dynamic care. So in terms of AI in the context of diabetes, let me just mention some examples. So there are already available applications, and probably you know this predictor, this retinal screening by Google DeepMind for predicting retinopathies. There are different predictors, people with semi-events, etc. There are also algorithms that have been approved by the FDA, by regulatory societies. You can have also AI-enhanced insulin dosing. There are applications related more to natural language processing to extract information from the electronic health record, etc., etc. So there are still a lot of possible applications for AI to the field. And just to mention a few, one of them would be the prediction of personalized disease trajectories. I will mention that later a little bit. Obviously, tailored interventions, guided therapies, etc., analysis of voice or image to detect different types of comorbidities. Obviously, the field of wearables monitoring is a clear field of application of AI. But let me mention these three as to me are more important, and I will pay attention to them in the subsequent slides. So something which is interesting to me is the early prediction of endpoints, in particular the early prediction of diabetes, or early identification or early prediction of comorbidities within the once you have diabetes. And I'm going to comment a little bit on digital twins, or maybe more on simulated patient to learn on data, right? So why predictors are important? Because essentially early identification means better outcomes, or in the negative, say, delayed diagnosis often means damage, nephropathy, etc., etc. AI can detect preclinical signals in many, I mean, in all this information that we left in the health system when we pass through the health system. For example, laboratory test, routine lab test, for example, uric acid or other measurements are quite interesting, as well. It gives a lot of information on possible diabetes, medication, and healthcare use patterns are also very informative, and obviously lifestyle and other social determinants. So predictors help to stratify patients and enable targeted prevention. And in general, something which is very attractive to me is that prevention has a very transformative power. It can transform the healthcare system from reactive to proactive. So it's what we call precision preventive medicine. So we have like two different situations. One of them would be before the diabetes. So there is no risk, yes, yeah, there is general population. So this is a quite complex problem because we have a population which is not specifically controlled. So we have the information that we have. So you left information because you go to for a flu or for something, and they do you some laboratory tests or whatever, but you may have very few data on a specific patient. And actually, the younger are the patient, the worse, because the younger you are, typically you go less to the health system, and you have an irregular data record. But once you are in a risk population, then you have a lot more of control. So you are a controlled population. There is abundant data on you. These data are regularly spaced in time, and typically you have data which is relevant for the disease. And you probably will have biomarkers. So biomarkers are quite important. I'm not going to talk about biomarkers. I let that to Marta, but biomarkers are quite interesting because there are, among all the variables we can think of, they are the most informative. So let me show you an example, which is not something that we developed, but it's not diabetes, but the concept is similar. So we take in general population a lot of variables that exist for people, a diagnosis, visit to the health system, etc., etc. There are variables that by themselves are not probably are not very specific, but you can build a predictor. So this is ovarian cancer. There is a prevalence on 1 is 78. So in theory, you should screen 78 women to find one positive. But you apply the predictor, you reduce that to 12 women for finding one positive. So in a way, you redefine the risk population based on a number of variables that you have from people, right? So just for finishing, let me mention the importance of synthetic patient. So something which is very important to me is that beyond the complexity of medical data, because they are heterogeneous, multimodal, etc., so medical data has an extra problem. They are protected by general regulation of data protection. So in Europe and in different laws in other countries. So one of the solutions to try to overcome this problem is to generate high fidelity synthetic patient data. So there are different ways in which we can do that. The most famous, but there are more now, and now with these generative models, there are different ways of doing that. But this is typically what you do is to put in competition one generator and one discriminator, and but with the idea that the discriminator says, okay, this is not when the generator generates something which is unrealistic, they say, okay, this is not in that case on the left, this is not a picture. What, and there is a backpropagation, meaning that this is not a picture because it has not eyes. So then the generator start to put eyes. And then the discriminator said, no, but this is still not a face because it has not ears. So they put ears. So when they enter in competition, after millions of rounds, at the end, the discriminator is unable to discriminate between the fake and the real, synthetic and the real. So you have a high fidelity synthetic pictures in that case. So we can apply exactly the same concept to electronic health record, and you can generate patients with high fidelity patients. So let me mention briefly disease trajectory. So disease trajectories is you have different possible diseases. This is in principle, in theory, could happen in any order, but if you go to a cohort and you see how they occur, so you can deduce that obviously you have to be first obese, then diabetic, and then you can have a comorbidity, but typically it's not the other way around. So typically you don't have a retinopathy, then you are obese, and then you have diabetes, right? It can happen, but it's not the normal way. And then we call that a disease trajectory, and you may have other diseases which are completely unrelated, in which it can happen before or after, and etc. So we can call the patient as disease trajectories, and we make a quite simple coding, but still informative, in which each patient is coded as a list of visits to the health system at a given age, and obviously the patient has a sex, is male or female, right? So we have a collection of visits to the health system with a pathology, with a diagnosis or whatever, and the age, right? So when we simulate the data, we see that they're quite realistic, these data. So you look at so in the Y you have the synthetic, and the X you have the real. When you compare, for example, the frequencies of diagnosis, they are quite similar. When you compare the number of visits per patient, they are more or less equally distributed across ages. When you compare the co-occurrence of comorbidities, they are quite similar. So you can see that it's more or less realistic. And you compare the disease trajectories, they're quite similar. Obviously, they are not perfect. We are trying to polish a little bit, but it's something that, even though that there are synthetic data, you can find and you can derive patient trajectories from the synthetic data that look very much like the real patient, the real patient disease trajectories. So just for finishing, because I took more time than I should have. So diabetes is not one disease, but many parts needing personalized dynamic treatment. The AI is already transforming screening, prediction, and decision support. And but this success relies on the availability of data. Especially biomarker will be quite interesting data. So synthetic patient can be a solution for fostering the clinical research, because it's a way in which that means you can circumvent ethical issues. And obviously, clinicians must be part of the process to ensure ethical, effective implementation, etc. So thank you very much for your attention. And let me stop.
I will, following Joaquin's presentation, I will use metabolomics, which is some of the work that I've been doing for the past 10 years, just as an example of what we have been discussing about biomarkers and prediction. So briefly, I will speak about sorry, it's the, no, yeah, now you can see it, right? Everything? You can see the screen, the full screen? Yes, perfect.
Yes.
So the future of type 2 diabetes prediction, do metabolites offer insights beyond traditional risk factors? And this is a brief overview of my talk, so I will cover some of the precision medicine and metabolomics concept for those who are not familiar with metabolomics. Then I will give an example of metabolomics and type 2 diabetes from a meta-analysis that we published a couple of years ago. And then very briefly, a case study or an example of acylcarnitines and type 2 diabetes. And I want to start by saying that traditionally, epidemiology and medicine in general has focused mainly on the relationship between exposures and health outcomes without that much insight into the biological mechanisms. However, in the past years, the scientific community has been leading more efforts to what's called like systems epidemiology approaches, where several different fields collide to integrate all this traditional knowledge from population-based studies and trials with more novel techniques that we call genomics, proteomics, lipidomics. And this, of course, leads to a big data that Joaquin has already introduced before. And of course, this needs a lot of bioinformatics and computational knowledge to be able to disentangle what we are finding. The integration of all these omics data with lifestyle data and diet data, that it's mainly what I do, can help us on the one hand to understand the biological mechanisms underlying a disease, for example, type 2 diabetes, or the complications of type 2 diabetes, but also it could help in the identification of biomarkers that can predict diseases years before the onset. And ultimately, help us with all these precision medicine approaches that tailor the medicine to particular individuals more in general. One of the omics, of all these omics that we have, that has a crucial role in cardiometabolic diseases, it's metabolomics. Metabolomics is more time sensitive than other omics such as genomics, and can be more easily influenced by the environment, by the medication that patient takes, nutrition, physical activity, and many other risk factors. The metabolomics profiling, or the understanding of our metabolome, can be indeed a key field to a more personalized medicine by helping individual risk stratification, by identification of biomarkers, and the therapy response prediction to different exposures, for example, a medication. But what is metabolomics when we say metabolomics? So metabolite profiling, or metabolomics, is the systems analysis of small molecules or metabolites in a given biological sample. Usually it's blood or urine, but there can also be done in saliva or feces. A metabolite is a low molecular weight biochemical that can be detected in a biological sample. Some of the metabolites that are include amino acids, lipids, sugars, organic acids, or nucleotides. And common techniques for analyzing that are liquid or gas chromatography, or NMR, which is different techniques. And then we can do more like metabolomics, more targeted, which means hypothesis testing, more directed, and we know which metabolites we are looking at, or more untargeted, which is just like getting all the peaks, for example, from the LCMS, and just getting unknown signals that we have to understand by data analysis and linking them to data sets what they mean. Here, this is just an example of some of the metabolites. For example, I have been working with the Broad Institute in Boston, and what we All these metabolites and these groups include amino acids, bile acids, carbohydrates, organic acids, and many lipids, including lipids from different long chains and short chains and different groups of lipids. And as an example, I would like to show you how metabolomics can be used as a biomarker of type 2 diabetes by showing the results of this article that was led by Jacob Morse, who was a PhD student at the time, and it was published in Diabete Schaar. So since several decades ago, there have been several cross-sectional studies and prospective studies that have demonstrated actually that metabolites are associated with type 2 diabetes in these case control studies where they look at the differences between metabolites in cases and controls, but also how metabolites can predict type 2 diabetes. And what we did here, it is like do a systematic review of all the literature that was out there, which included more than 70,000 participants. In this case, I'm showing the results for prospective studies and more than 11 cases of type 2 diabetes, incident cases during the follow-up. And in total, we were able to meta-analyze more than 400 metabolites, and about 120 were associated with type 2 diabetes. As you can see here, some of them in the red part were associated with increased risk of type 2 diabetes, and on the blue part with decreased risk of diabetes, and some of them we did not find associations with type 2 diabetes. Just to dig a little bit more in, you can see here some of the results of this work. For example, you can see the group of the metabolites, including BCAAs, which are very well known to be associated with diabetes, and we had some large number of studies for some of the metabolites, for example, the BCAAs, like more than 20 studies, and it was consistent that the hazard ratio, as you can see, it's above 1, which means that's higher risk of type 2 diabetes, and that was consistent across the study. We also looked specifically at acylcarnitines. It has been shown that acylcarnitines from different length chains have different associations with diabetes. Some lipids, including ceramides, have been associated with more risk of type 2 diabetes in several studies, while some lisophosphatidylcholine have been inversely associated with type 2 diabetes. So from this work, we concluded that several plasma and serum metabolites, including some amino acids, lipids, and carbohydrates, were associated with type 2 diabetes risk. Now, just as a case example, in this paper that we published in 2019, we were very interested in looking at how acylcarnitines were associated with higher risk of type 2 diabetes in individuals at high cardiovascular risk. Just briefly, these acylcarnitines can be derived either from diet or from internal degradation, and the main function of L-carnitine is to transport fatty acids from the cytosol to the mitochondrial. And when there is an efficient beta oxidation in the mitochondrial or mitochondrial dysfunction, this could lead to accumulation of these carnitines that consequently have been associated with insulin resistance and inflammation. So we used a targeted approach to look at all these acylcarnitines. In total, we had 27 acylcarnitines from different subtypes and different length chains. And we calculated an acylcarnitine score that was calculated using the weight sum of the selected carnitines using machine learning models, elastic net regressions. And then we computed two different models. One for conventional risk factors of type 2 diabetes, another with the carnitines. And here is where I want to make my point, that we compared this traditional model that was, of course, very predictive of type 2 diabetes because we included traditional factors such as age, smoking, hypertension, physical activity, and fasting glucose, that we all know that it's one of the main predictors of type 2 diabetes. The hazard ratio were about 4 for the model without acylcarnitines. And then when this score of the plasma acylcarnitines was added to the model, the hazard ratio increased quite a lot. However, when we use RAP curves to compare the predictive value of these models, there was slightly an increase, but not much increase. So here, my question, or what we could discuss, is whether indeed doing all these more fancy techniques and really like using big data and novel omics data could really predict much more to what we already have for type 2 diabetes, like fasting glucose or HbA1c. However, I think it's important to identify these novel metabolites because this could improve our understanding of disease mechanisms and potentially improving prediction and facilitate precision medicine and risk stratification for those patients at more risk of diabetes. We have identified quite strongly that there are several blood amino acids that have been associated consistently with the risk of diabetes, including BCAAs, amino acids, acylcarnitines, and glutamine. But really the question is whether these metabolites can improve disease prediction beyond traditional risk factors, and whether this metabolite score or any other of the metabolite scores that we have been computing in large datasets can be implemented in daily clinics. Like, are we there yet, or what else do we need, right, to make this happen? And I use this just as an example for discussion.
I think it's time for our panel discussion. Thank you both for the presentations. I think that really anchored the discussion well. And I think let us start with a few questions that we had in advance and that also came up during the session. And Mihaela, can I hand over to you to start?
Yeah, thank you so much, Marta and Joaquin, for these presentations. Let me start with asking Joaquin, it was such a good overview of all the complexities of diabetes, and also to some extent what makes it hard and interesting from an AI point of view to try to address these questions. So you mentioned the link between diabetes and other diseases. Some of these links, I assume, will be causative. Some of them may be, we can't prove causation, but it is clear a correlation between these different links. And there is also a question of when this changes in the other diseases, or when the occurrence of these other comorbidities occur. Do you feel that there is a need for development of AI tools to look at the timing aspects as well as the relationships between diabetes and the related comorbidities? Is something like this useful because of interventions? Is there need for a particular type of AI technology to solve these links and understand better these links? And if yes, what would be needed and how would we declare success? And maybe what type of data would we need?
Good. Okay, there are lots of questions. It's not one question, there are lots of questions. Well, I mean, at the very beginning, you say about the relationships, so I'm not an expert in diabetes, but I think that obviously there is a causal relation between this disease and the comorbidity. So, and actually, it's something very interesting because you can see this disease trajectory is very clearly marked. So there is typically the obesity that creates an environment that ends up in diabetes, and then there are different comorbidities which are derived of this status in the body. From the point of view of prevention, of the clinical intervention, obviously they are very important. And actually, I think that AI can work very well for advancing what patient is in risk of given or specific comorbidity or not, and probably it's much easier to develop predictors once you have diabetes, because once you are diabetic, then you are under control, and then the system extracts a lot of data on you, and a lot of data which are more or less clearly distributed in time. It's not that like in general population that we may think people who has one analytic, then 2 years with nothing, and then another analytic and one recommendation of treatment. But in that case, in the case of diabetic, then you have a lot of data, so you can use this data. So and actually you may have even more high quality data, like the data that Marta was mentioning. So probably you will have maybe even metabolomics data from the patient, or at least some analytics of metabolites which are relevant for the disease. So predictor will be more or less easy to do. From a practical point of view, obviously, it depends very much on how your health system or your hospital has access to the data. But from the point of view of the implementation, it's very important that you take data that are already in the health system. So if you are because of the digitalization of your health system, you are collecting data and you have a database or whatever, and you can reanalyze the database of patient. I mean, on monthly basis or whatever, and you can alert if some of the patient has a risk of whatever. So in that case, it's something that can be more or less easily implemented, and I think that from the point of view of the possible intervention of the clinics is fantastic if we could do that.
What about comorbidities, though? What about the comorbidities, the relationship that you mentioned between the primary diabetic disease and potentially comorbidities, I guess, that are either triggered or maybe enhanced by diabetes? Do you think there is a potential with the eye there?
About this what?
So as you mentioned, there are relationships between diabetes and a variety of comorbidities.
Yes.
Do you see any potential for AI to help with either identifying the impact diabetes has in the incidence of new comorbidities and or changing the trajectory of diseases and the course of these diseases by potentially accentuating them?
Okay, I'm not sure how I understood the question, but you mean if you are interested, for example, in understanding the effect or the causal effect of diabetes in kidney failure, you should compare kidney failure within diabetes with kidney failure in non-diabetic patient or with more or less similar characteristics. Probably you can use more classical statistic to do this comparison, survival analysis, but probably the use of AI is more interesting from the point of view that you can much better handle with this heterogeneous data, because you have many type of data, numbers, labels, etc., ordered, unordered, etc. So probably it will work better.
Thank you. I also had a brief follow-up question for you. Have you looked at all into subgroups? Because you mentioned disease trajectories, and my question was sort of, have you identified subgroups of patients that would have different disease trajectories and what they would depend on?
Not yet at this point, because I mean, what I show you is the interest here was to build up this synthetic patient and then to compare synthetic patient to real patient to see if they are more or less realistic or not, right? So then we have not go to the detail of subgroups of patients, but you can, definitely you can. You take real data and you have enough data, you can identify different subtypes of patients with different disease trajectories.
Okay, thank you. Then, yeah, we had one comment about data collection in Italy, also on diabetes. If you want to mention something about that live, Marco, please feel free to unmute yourself as well.
Yeah. Good evening, everybody. Thanks for this webinar. Very interesting. Yeah, I'm a PhD student doing, and I'm a physician, internal medicine physician, doing my PhD in AI in medicine. I actually was in Cambridge until a few weeks ago. So I'm really happy to share my experience. And yes, diabetes is a very complicated disorder. We see it as a single disease, but actually I feel that there are different subgroups of patients, different nuances. we know very well how diabetes evolves. Like, you know, that there is glycated hemoglobin levels which are related to the risk of developing complications. So these are direct effects of glycated hemoglobin in the blood, so of sugar levels in the blood. But having said this, I think there is still much to learn. And we have a lot of data in Italy, especially. We have a lot of data, but I think in many countries, because this is a chronic condition that is followed up for many years, there are many different treatments, and treatments are evolving year by year. There are new guidelines. So I think we need to do data intelligence, to do data-driven medicine in this case, to have real-world data analysis. And often this data is messy. It comes from everyday clinic, and often it's difficult to really make sense of it. So I think we need to link with data scientists and try to put some order in the data, doing causal analysis, doing longitudinal studies, longitudinal analysis, trying really to take the most out of the new analytical techniques we have. So I think this is a very good example of some place where good cooperation can happen.
Thank you. Thank you for the comment and also for sharing the resource.
Can I add something on this point that I was thinking on diabetes heterogeneity, just to, I think there has also been a lot of research, or not a lot, but some research showing that actually the genes related to type 2 diabetes, like all these polygenic risk scores, they are pathway specific. There has been actually all these subtypes of patients that their genetics is more linked while having diabetes to insulin resistance, or the function of the pancreas, or immune responses, or glucose metabolism. So there have been different types of genes and polygenic risk scores linked to the different trajectories that leads to what Marco was mentioning about all this heterogeneity and the difference in type 2 diabetes. And I think here is where all this big data and how AI can be implemented could help in the patient, because not all patients are the same. They don't develop the same complications, and understanding all these pathways behind it could help on guiding the treatment.
Sorry, Tim, I need to jump briefly, if you allow me to, when what Marta said now. So it seems like Marco triggered the chain, because I think it's very interesting in what you say, Marta, because as far as I know, polygenic risk scores are considered just about risk, but not necessarily about the trajectory of the disease and how fast the disease goes. And I think where AI can contribute potentially a lot is linking risk with progression of disease, speed of disease, and looking jointly at both omics information and longitudinal information. And that's indeed very exciting, I think. Sorry, Tim.
No, I agree.
Let me make a short point on that you said, Mihaela. You may develop a polygenic risk score on a disease trajectory. So at the end, you select the patient who follow this trajectory, and you can develop that. So at the end, it's a matter of what is the endpoint that you are targeting for developing this PRS. So nobody has developed it as far as I know, but it could be developed.
I think from a machine learning point of view, this can be done and is exciting. And I think what's interesting is not only an endpoint, but as I think Marco and Marta a little bit alluded, the trajectory may be also very different. They may evolve at different speeds. And I think that makes it exciting, because it's not a conventional risk analysis. It's much more a time to event analysis, but it is maybe even beyond that, because there may be multiple events that could be triggered and an entire trajectory that can be modulated by these genetic factors or these omics factors. So I think it's exciting also from a machine learning point of view.
And of course, for the machine learning point of view, all the CGMs that Joaquin are mentioning and we didn't have before, but are becoming very popular now. I don't know if in the clinics, but for sure in the research setting where we are, this will give an insane amount of data. And here AI and machine learning would be key to really understand all these changes and for me, that's super interesting if we link that to the nutrition and what's the difference of what people is eating and how they glucose changes depending on what they eat, and why some people react one way and others react other. I mean, those with diabetes, of course, but even for the general population.
And something which is very interesting for the audience is that machine learning, one of the properties that has machine learning that I like a lot is that you can use machine learning to discover what is the relationship of the variables with something, and you can do a predictor. But at the end, the predictor is selecting the variables which are important. So at the same time, you are obtaining, you are looking for the optimal way of distinguishing between class A and class B, of risk patient and non-risk patient, but at the same time, the predictor is selecting what is relevant for this distinction. So you can make discovery of variables which in principle were not important, or were people didn't pay attention to that variables, and that variables reveal themselves as important for taking the decision. So this is the double edge of the machine learning, which is interesting. It can be useful for predicting, but at the same time, it can be useful for discovery what variables are important.
Yeah, also following up on your presentation, Marta, I had a question basically about you talked about metabolomics, which is very far, like it's basically almost the other end of the spectrum when we think about polygenic risk, and then you have metabolomics, which is much further down the biological chain of events, right? And I believe it's much more difficult to measure in patients, and that's why I was going to ask, do you believe that metabolomics would play a role in risk prediction, maybe in only a higher risk population that has first been identified by a more like parsimonious model, and then use metabolomics in this high risk cohort to further stratify? Or where do you see the clinical application?
And yeah, that's a very good question. I'm not sure I know the answer, because I've been myself thinking about it, like especially when I presented this, like I think with metabolomics, there's a lot of changes. So probably the same person, if we measure metabolomics at different time points, at different ages, this will change, right? When genetics stays constant. I think it gives us insights again on what's happening, which pathways are affected, whether we can implement this in clinics is what's been my question. Like we've been like BCAAs, they have been, I don't think there's a study that has not found an association. I think it's been clear in many studies, but it has not been implemented in clinic, whether because if it's expensive, whether because we have already other biomarkers that help. But I think the part of stratifying patients that you're mentioning, or the precision medicine part, and maybe we're not there yet, it's where I think could have a clinical impact. Like maybe it's not for all the 90% patients that maybe are fine with just having HbA1c or fasting glucose, but maybe there's the tails of the bell that could benefit from knowing better their metabolite profiles at baseline, and see how medication or diet or physical activity modulate those. And they could even be, in my view, a target for more like, or like proteomics, that it's now becoming also a hot topic, more like a target for designing some pharmaceuticals that could target like decreasing BCAAs, for example, or dietary interventions. But I don't, at this point, as far as I know, we are not as far as I know, using that in clinics much.
Okay, no, very interesting. And maybe even something that you would have identified in your studies. I mean, you don't have to perform metabolomics for all patients, right? Maybe you just test for one of the things. We also have a couple of questions from the audience. One of them was from Karina. If you would like to unmute yourself and ask a question live, please feel free to do so.
Yes, thanks for presentation. Great presentation. My question was relating with the deployment of the predictive models in hospital settings. So if the models you developed are already used in clinical setting, or is just in academic, is still in development?
You mean the one of the ovarian cancer, right?
Yes, exactly.
Yeah. So this is not yet in use in clinics because it needs some regulatory approvals. They are on the way of I don't know how long will take. Probably it's not short time. We have another one for discovering patient of hepatitis C which had not been diagnosed with no diagnosis. So people who has hepatitis C that typically are people who are not in the risk group. And with this case, we are doing a small prospective clinical trial with the predicted in 2024. We are trying to discover them in 2025. If that works, probably the clinical application will be immediate. But in our particular case, we have not yet these predictors in production within the health system.
And you have already published on the work on ovarian cancer, or are you good?
Not yet, but it's submitted, and I have a preprint that I will send you by the chat.
Okay, thanks a lot.
Thank you. Mihaela, can I hand the floor back to you for...
Yeah, yes, thank you. I was very intrigued by what Marta said in her presentation. I thought it was very interesting on many levels. So Marta, I have two questions to you, again, coming from an AI point of view. So one is this issue of timing, the fact that things may change. And like you rightly said, measuring at different moments in time, metabolomics may be different on different patients. To some extent, AI could help with this issue of localization, potentially. So could try to understand, again, relative positioning in time, if you like, of a certain factor. However, the challenge remains, like you rightly say, the limited data, the fact that maybe you measure only once in a while and you measure relatively limited data. Do you think that there is an opportunity here to do something more, either through more aggressive data collection, which would allow us then to look at the impact of maybe genetics, lifestyle factors, maybe activity, as well as food. And if you track all of that together with a subset of patients that are monitored over a longer period of their lifetime, do you feel that that could be, from a machine learning point of view, I think that would be very exciting and possible. But do you think from a medical point of view that this would provide the clarity you need?
I think and medical doctors can correct me, but I think it's very difficult to find the clarity of the things. But there's been, and actually we've been doing some studies. For example, one of the ones that I presented here, where we had metabolomics at one time point and after 10 years of follow-up. And we look at the changes. And we saw some different things from the baseline. And this has also been done, for example, in my field of looking at dietary interventions and see how nutrition or physical activity could change from 1 month to 3 months to 6 months. So because we know that metabolomics is changing, I think from both points of view, this is very interesting. However, they may give us different questions, right? Different answers to different questions. So maybe having something at the baseline could be related to what Tim suggested, more about the stratification of patients, right? What's the different metabolite profiles at baseline? How can we stratify patients based on that? And the other one with the changes can give us some insights on how, and I don't think that has been done, but maybe on how the disease is progressing, right? So maybe for those who have more complications of diabetes, they have more changes before. So I think this definitely could lead some more light, and it has not been done, for example, in large populations as metabolomics at one time point has been done. So for sure, I think that would be a very interesting thing to work on.
Amazing, thank you. Because we're getting closer to the end of the session, before we wrap up, we would like to ask each of you basically one final question or one final comment. What's the current problem in your own research that you hope that AI will solve in the future, or you hope that maybe in existing AI technologies could be applied? And maybe again, Joaquin, could we start with you? Not to put you too much on the spot.
Okay, I mean, maybe there are a lot of exciting problems to be solved with AI. But to me, probably the most interesting problem to be solved is the prediction. The prediction, because we can make a lot of predictors. It's not that we can also learn from the predictors. It's that the predictors, once integrated in the clinical practice, they will change the clinical practice. They will make the health system, or they will transform the health system from reactive to proactive. So we will have we call it precision prediction, right? So I think that maybe it's not the most exciting problem from the intellectual point of view, but from the medical point of view, being able of systematically being able of predicting the next stage of the disease or what you need in the future will transform the health system. So to me, this is the most interesting part.
I can jump, Tim, and what's interesting in what you say, Joaquin, from an AI point of view, is not only making predictions, but making predictions given uncertainty estimation. And because you don't want maybe to make predictions that you are uncertain about, and you may need to know when you are certain enough, and potentially what type of additional information you may need about these patients to make the proactive intervention, which I think makes it interesting.
Of course, but these are details, because we are at the point in which we don't even have very simple predictors. So, but I agree with you.
Thank you. Marta, could I ask you the same question?
Yes, so maybe, and then I switch slide topics, but because you ask in my research, I will tell you why I think AI can help in my research. So sometimes when I talk about nutrition and precision nutrition, I ask the audience, and one of my first slides is like, Alexa, what should I eat? Right? So does Alexa really know what should I eat? So in one problem that we have had in nutrition is all these questionnaires that people fill in, and sometimes they are very biased because they don't remember or for many other reasons. And with AI and all this taking pictures of the food that people eat, this could really help us, the nutritionists, to have more accurate data on what people is really eating. And there have been already some programs and apps that are trying to do that. And I know we're switching topics, but of course, this was on my field and why I think for me it's one of the interesting things of AI. And of course, this can be used then to predict diabetes or other diseases.
Very interesting. Thank you so much. Certainly also a very creative use. Without further ado, first of all, thank you so much to our panel. That was really interesting and really amazing. I'm going to use these last few minutes to tell people about what's going to happen next. Our next session is going to be on the 17th of June, and it's going to be more of like a personal session where we gather a few people to talk about experiences of clinicians in an AI lab. Basically, what have we learned about machine learning? How's the world different from what we know? And how can the two worlds come together to create something meaningful? And this session will be up on YouTube soon, as usually done. Also feel free to let others know about these sessions. And please do join us in summer from 12th to 14th September, when we are going to have our AI and machine learning in medicine summer school that's specifically tailored to clinicians and healthcare professionals in general, where you can basically from the ground up use machine learning tools, get a feel for the cutting edge, and basically get quite a comprehensive insight into the most important topics right now. So please join us there as well. Thanks again for being here today. Really amazing session. Thank you for joining us.